Today we are discussing an interesting case with the renal lump, and we will see how it evolves and what was done for this child. Dr. Preetham is going to present the case, and it would be followed by a relevant review of literature by Dr. Puneet.
Good evening everyone. I am presenting the case of Riaz, 4-year-old male child, resident of village Khira, district Mewat, Haryana, and the informant was father who was reliable. Child is 4-year-old male child, presented with complaints of fever for 20 days, abdominal distension for 20 days. Okay. Good evening everyone. I am presenting the case of Riaz, 4-year-old male child, resident of village Khira, district Mewat, Haryana, and the informant is father who is reliable. Child presented to us with complaints of fever for 20 days, abdominal distension for 20 days, and pain abdomen for 20 days. The fever was insidious in onset, high grade, which 2 to 3 spikes were there in a day, and which was not documented. It was not associated with chills, rigor, or rashes, and there was temporary relief on medication. There was no worsening or improvement over last 20 days. Child was also having abdominal distension, which was noticed by father as bilateral lump in bilateral flank area 20 days prior to admission, which was gradually increasing in size and was associated with pain abdomen, which was mild, generalized, dull aching, and was not radiating to any side. And there was no history of change in intensity or character of the pain over last 20 days.
Size of the lump according to him?
Sir, father was saying that he can feel some lump in the bilateral flank area, which was around size of potato. There was history of weight loss present over last 20 days, and it was 2 kg in last 2 months. There was also history of loss of appetite, and there was
Yes, go ahead.
There was no history of hematuria, decreased urine output, poor urinary stream. There was no history of vomiting, nausea, or diarrhea alternating with constipation. There was no history of jaundice, and there was also no history of bleeding from any side, blood transfusion, swelling around the neck, or any other part of the body except for the abdominal lump. There was no history of tuberculosis or TB contact or chronic cough in the baby. Coming to the past history,
based on the history of present illness, just by history, what do you conclude?
As from the history, the chief complaints were fever, abdominal distension, and pain abdomen. So we can assume it could be infective.
And the fever, lump in abdomen also.
Yes, sir.
That's also a complaint. Yeah.
Yes, a localized swelling in the abdomen, pain abdomen, and fever for 20 days. So along with fever, we can assume that it could be infective pathology, and it could be because of involvement of hepatobiliary system, spleen, or it could be kidney lump. So we have to think in keeping in mind these systems.
So if, as the father is saying, the father is able to feel the lump on both the sides, you would feel more like the renal masses, or you said the liver or a splenic enlargement?
Sir, as the father was saying the lump were in the flank area, so we cannot by his description differentiate between liver mass or kidney mass. So we have to go for the examination.
That's right, but according to his history, the flank masses are there, and liver and spleen would be of different kind of
Yes,
lumps.
Yes, sir.
Right.
So more likely.
Okay,
renal
obviously,
mass.
I mean, this has to be decided after the examination what organ we are dealing with.
Yes, sir.
All right.
Sir, so we can keep the possibility of any infection, that is, it could be pyelonephritis. Coming to renal system, first of all, it could be pyelonephritis or it could be hydronephrosis secondary to some obstruction like posterior urethral valve, or we can also assume some cystic disease of the kidney. And
Okay, we'll see what examination shows. Yeah.
okay, sir. In the past history, there was no history of dribbling of urine or burning micturition or pain while micturition complained by the child in the past. The history suggestive of recurrent urinary tract infection was not there, and there was no history of similar complaint in the past, and there was no history of passing of urine in drops since birth. In developmental history, child can go downstairs with alternating feet. He can hop on one foot, and he can unbutton himself. He prefers to play in groups. He is having preferred friends, and he goes to toilet alone. He can brush the teeth, and he can name 5 to 6 colors, and he can follow 2 to 3 step commands. So by this history, development was normal.
What about speech? For a 4-year-old child,
So
development
he
of
can
speech
tell
is
story.
okay. Does he go to school?
No, sir. In the immunization history, child was unimmunized for age, and the reason was father was giving that there was no availability of nearby hospital or some center for immunization. That is.
Well, I think that all of you might be seeing patients coming from this region, Bebat. Lot of them are of this type. They don't go for immunization, and that's a backward area, and mostly we get cases like that. So nothing unusual in that. It's not that the hospitals are not there. They even have a medical college close by, but still this community is such that their children are mostly unimmunized.
In the family history, child is second in birth order. There was history of abortion 5 years back at 1.5 months of age, cause of which was not known. And child is having a younger sibling. She is 2-year-old female child, alive and healthy. In antenatal or perinatal history, it was uneventful. There was no history of polyhydramnios or oligohydramnios or any respiratory distress or any history of admission to the neonatal ICU. Coming to socio-economics history, father is farmer by occupation, and he is educated till 10th, and the child belongs to lower middle socioeconomic status by modified Kuppuswamy scale, and surrounding environment is not so hygienic. Hand hygiene was not there, and they used to go for defecation in open field only. And in dietary history, the caloric intake was 1350 kilocalories per day, which was appropriate for age, and protein was 20 grams per day, which was also normal for the age. So child was not deficient in calorie or protein intake.
So how do you assess the caloric intake in this child, whether it is normal or abnormal?
So we have to the present diet we cannot take, so we have to ask for the pre-morbid diet, and this can be done by 24 hours recall method, but it is also not very reliable because they can recall, so recall bias is there.
So what
It
is
is
the
roughly-
what is the recommended caloric intake at this age?
Sir, it is around 1350 or 1400 kilocalories per day.
You would like to tell how do you calculate the caloric requirement or recommendation for caloric intake around this age? Yes? Yeah. No, that's the method. You find out how it is calculated. But what is the recommended intake at this age?
So holidays.
So, what would be the normal or the recommended intake at this age? He is 4-year-old.
Little
Yeah.
more than 1,000, nearly about 1,300.
Okay, so that's what your calculation is. He gets about 1350 calories.
Yes, sir.
And what about proteins?
So 20 grams.
20 grams. And say if a normal child of this age is about 16, 17 kgs, so how many grams per kg he would be receiving normally? Yeah, so the intake is all right. Okay, we'll see in the anthropometric parameters whether this intake is really translating into the normal or the abnormal weight of this child. Yeah, go ahead.
Coming to the examination of the child was lying supine in the couch when he was examined. Child was febrile to touch and temperature was 101 degree Fahrenheit, and the child was tachycardic on examination. Heart rate was 130 per minute in right radial artery. It was good volume, regular, and there was no radial or radiofemoral delay. And child was also tachypneic. Respiratory rate was 30 per minute in lying position with no features of respiratory distress, with no retractions. And
30 respiratory rate per minute. Is it really a fast breathing for this child?
no, sir, marginal.
Not even marginal. Yeah. 40. Above 5 years, up to 5 years, you take 40 as a cutoff for fast breathing. Were there any intercostal retraction? Why did you feel that he is tachypneic?
No retraction.
So that is fairly normal, the respiratory rate.
Okay, sir. Blood pressure, it was systolic blood pressure was 98 and diastolic was 64 millimeters of mercury, which was lying in between 90 to 95th centile according to blood pressure chart, and it was in pre-hypertension range, and CFT was less than 3 seconds, peripheries were warm, and child was maintaining saturation at room air.
Pritam, any importance of blood pressure?
Yes, ma'am. As the child presented with abdominal lump, so it could be, as we previously discussed, it could be renal lump. So, some etiologies are there in which we can get hypertension, like in pyelonephritis or chronic kidney disease, or some tumors like film tumor, or some lymphomas and pheochromocytomas.
When you are describing renal causes mostly, or the tumors that you have talked about, the pheochromocytoma or even BIMS probably will have some hypertension. When you are saying that pyelonephritis as a cause, you probably mean pyonephrosis. Pyonephritis will not have definite lumps. It's the pyonephrosis when it is collected around the, I mean, it's a large
Yes, sir.
sort of dilatation that leads to the formation of lump, as
Hydronephrosis
the
will-
kidney being palpable as a lump.
Yes, sir.
Pyelonephritis would be just mild enlargement, and that probably would not be ascertained at least by the parents. Yeah.
It's a pyohydronephrosis or
Yeah,
hydronephrosis with
that's right.
superimposed infection. Coming to anthropometry, child was weighing 14 kg at the examination, and weight for age was between -1 to -2 standard deviation. Height was 96.5 centimeter. It was between -1 to -2 standard deviation, and weight for height was between -1 to +1 standard deviation. So child was normal according to age, and there was no nothing suggestive of malnutrition. And mid upper arm circumference was 14 centimeter, which was normal.
Okay.
So, and by
So
anthropometry,
by all anthropometric parameters is normal for
normal for
age. The height, the weight,
and
and
height.
weight for
Weight
height.
for height.
Okay.
On general physical examination, child was a little pallor was present, and from head to toe, Eyes were normal. There was no abnormality in iris or any proptosis or any abnormal jerky movement of the eyes, so as to rule out aniridia or proptosis or some other uh, features associated with malignancy. And there was no history of, there was no pedal edema or icterus or cyanosis or clubbing or lymphadenopathy over any side. And there was no history of petechiae or rash or any joint swelling or pain all over the body. And there was no history of, there was no sternal tenderness or no bony tenderness present. And also, when the child was examined, there was no difference in girth of any limb or any side of the body was not enlarged, so as to rule out hemihypertrophy. And on genitourinary examination, they were normal. No evidence of hypospadias or cryptorchism or any other abnormality.
Okay.
And
So she mentioned, Anand, she mentioned couple of things like in the eyes, she mentioned about abnormalities, abnormal movements. What could be the possible association that she is thinking? Can you work out? Opsomyoclonus, mostly neuroblastoma, right? Okay, yeah. And the Wilms tumor will have an idea, and the what about hemihypertrophy that she is mentioning about? What is the association?
So there is Wilms tumor plus there is hemihypertrophy of one side.
Okay. Yeah. So as there is a possibility of some tumor, it's important to look at these signs which might point towards a particular etiology, right?
Yes, sir.
also, there were no neurocutaneous markers or any other dysmorphism or anything.
Okay.
Coming to per abdominal examination, on inspection, the abdomen was distended, flanks were full, flank fullness was there, and umbilicus was central, it was inverted, and visible veins were present over the abdomen, and all the quadrants were moving well with respiration. There was no abdominal wall edema. On palpation, bilateral ill-defined mass was palpated in the lumbar area, which was 9 to 10 centimeter from loin to groin, and it was ballotable on bimanual examination, and also it was not moving with respiration. Fingers can be insinuated between the costal margin and the lump, and there was no fluid thrill present. Uh, Liver was also palpable, which was 2 centimeter below right costal margin in mid-clavicular line, and the liver span was 6.5 centimeter. Spleen was not palpable, and hernial sites were normal. On percussion, dullness was present in bilateral flank area corresponding to lumps observed in the palpation, and there was no shifting dullness elicitable. And on auscultation, vowel sounds were present, no renal groove or nothing was there.
Okay, so your abdominal examination shows there are masses. Are they equal on
Yes, sir,
both the sides?
approximately equal.
Approximately equal. And by your description, what do you feel it is?
Sir, the masses were symmetrical and smooth margin, rounded, and sir, they were ballotable on bimanual examination. So we can assume that it was not spleen on the left side, and we can insinuate the finger below the costal margin between the mass and the costal margin. So it is also the differentiating feature between spleen and the kidney masses. And splenic notch was not there, so most probably it was renal mass.
So bilateral renal enlargement is there.
Yes.
Okay. And it appears to be a uniform enlargement, or
So it was uniform enlargement,
Uniform,
smooth
okay.
margin and rounded borders.
What about renal angle examination? Any tenderness?
Yes, sir. There
anything?
was renal angle tenderness on both the sides, sir. On both the sides.
So based on this, what could be the differentials? Anyone? Stand up, student.
Surya?
Child is having fever for 20 days and mass arising from the lumbar region, bilateral regions, and he is having loss of weight and loss of appetite also. So it may be infective, infiltrative or malignancy DD, or infective like pyonephrosis we can keep, or malignancy like neuroblastoma or Wilms tumor or any lymphoma, or it may be cystic disease which may be secondary infected like polycystic kidney disease, so it may be infected by secondary causes, or it may be sometimes it may be like renal vein thrombosis which will cause renal enlargement but associated with infection. It may be some having, but it may child is having loss of weight, loss of appetite, so the first two possibilities may be infection and malignancy.
Okay. And the malignancies that you said, of the two, say Wilms tumor and neuroblastoma, which is more likely?
So actually, Wilms tumor.
Yeah, bilateral Wilms tumor, actually both tumors bilateral are uncommon,
Yes,
right? But of the two, which is less uncommon to say?
Neuroblastoma, sir.
Bilateral neuroblastoma would be more common,
Less common, sir.
less common compared to Wilms,
Yes, sir.
right?
Yes,
So
sir.
Wilms becomes more likely,
More likely, sir.
yeah, of the two,
Yes, sir.
right? Okay. And then third possibility you said the polycystic disease.
Yes, sir.
Okay. Any other?
Or renal vein thrombosis, it lead to
Renal vein thrombosis. Could you discuss it out whether it is really a possibility or theoretically we could think of renal vein thrombosis? Renal vein. Yeah, and that is more catastrophic type of presentation, and mostly there is hematuria as you said, and they would be pretty sick. Again, there has to be some obvious reason for the bilateral thrombosis of the renal veins. Okay.
And out of those cystic diseases, which could be possible?
but polycystic kidney is most common.
Polycystic would be, because
That will be
multicystic kidney bilateral is incompatible with life.
uncommon.
But not it.
It can, yeah.
Later on, they end stage renal disease.
Yeah, in childhood you get cases, and maybe
For at least 4 years, we can
yeah.
keep a possibility.
any storage disease will you think of? Any of the glycogen storage diseases? Yeah, they might have renal lump, but then will there be any other organomegaly?
Epidemiology will be there.
Mostly hepatomegaly is also there, yeah.
But the child also having epidemiology.
The liver is how much? 2 centimeter.
centimeter.
At 4 years, 2 centimeter, unless it is, consistency is abnormal, you would pass it
Because
off.
span is normal, so
So
one
span is normal, but you are right, a glycogen storage disease type 1 would have nephromegaly also.
Rest of the systemic examination, it was normal, sir.
It was normal, okay.
Okay,
So,
no. Coming to cardiovascular examination, S1, S2 were heard, which was normal, and no murmur was there. In respiratory examination, bilateral air entry was equal, chest movement was normal, and there were no conducted sounds or any retraction or signs of respiratory distress was not there. or there was no decreased air entry on any side of the lung. And in CNS examination, child was oriented to time, place, person, and there was no abnormal movements, and so that's it.
No lateralizing signs or no meningeal
Lateralizing,
signs.
or no
Okay.
cranial nerve palsies
Okay.
or any hemiplegia.
So with this differential that there, do you want to add something, or what is your
Sir, summary I can.
yeah, you summarize whatever we have discussed, partly the differential diagnosis. If you have some more to add.
The child is 4-year-old child with fever for 20 days, with bilateral renal mass, with anemia, with no hepatosplenomegaly, with no lymphadenopathy, and with normal anthropometry, and developmentally child was normal. So we can we can divide the causes in infective causes, obstructive causes, neoplasm, which could be malignant or benign, and congenital anomalies. So first of all, the infective causes like pyelonephrosis, or
Pyonephrosis,
pi-
not
sorry,
pyelonephrosis.
pyonephrosis, and granulomatous, xanthogranulomatous pyelonephritis can also present, and hydronephrosis along with the urinary tract infection, superimposed urinary tract infection, and in obstructive also hydronephrosis can cause renal masses, and localized renal abscess can also present in enlarged kidney size. And so second possibility we will keep malignancy. So as we discussed, Wilms tumor will be the more likely possibility. So this is the presenting age for Wilms tumor. Although it is unilateral, but bilateral can be there. So we will keep the possibility of Wilms tumor in the second diagnosis, differential diagnosis. And so also we can keep the possibility of neuroblastoma. So as in further later on in investigations, we will rule out these malignancies. And other causes like renal cell carcinomas and nephrogenic rest,
The uncommon
So
tumors
they are
of
uncommon tumors,
yeah,
global
they are very
sarcomas.
uncommon,
But
and
they
let
can
us
be
not go into the details of those tumors. And if we find that it is a tumor, obviously the histology would be required. Okay, so
And so lastly, congenital anomalies we should also keep in our possibility, like multicystis congenital disease. And so it is also bilateral incompatible with life, but unilateral can be there, but it is less likely here. And autosomal dominant polycystic kidney disease, which although the age is later in the life, but it can also present in childhood. In our age group also it can present similar features like abdominal lump, flank pain, and hematuria,
okay.
and fever. And so autosomal recessive, it can
All
also
right.
present.
So any other possibility any one of you would like to keep? Let us see how we can investigate this child. What would be your line of investigation?
Uh, First of all, as the child comes to us, we will do the complete hemogram, and also child was anemic, so we will do peripheral smear to look for the cause. And biochemical examination will include LFT, liver function test, kidney function test, calcium, phosphate, uric acid, and serum electrolytes. As we are keeping in our differential malignancy, so we will also keep the possibility of complications of malignancy, like medical emergencies. So we will do uric acid, phosphate, calcium, and serum electrolytes. And
Yeah, these abnormalities are not all that common with Wilms tumor, but then certainly if you are thinking of malignancy, one would like to look at these abnormalities. Yes.
So to rule out tumor lysis syndrome, we will do the
Yeah, that's what I said. The tumor lysis syndrome is not all that common with Bim's tumor.
yes, sir. And sir, urine routine microscopy we will do, and culture sensitivity we will do to rule out infective causes. And also the ultrasound abdomen and KUB will be the first line of investigation in our case. And then these, sir, should I tell the investigation?
Okay, so do we have the investigations available with
Yes,
us?
sir. Yes, sir.
Yes.
Sir, at presentation, ultrasound KUP was done, which showed bilateral grossly enlarged kidney. Right kidney was 12.6 into 6.9 centimeter, and left was 11.7 into 4.2 centimeter. There was complete loss of architecture was there, and vascularity was there in the mass, and there was no evidence of hydrouretronephrosis. So impression was made of Wilms tumor versus bilateral renal lymphoma. So again,
Okay, so the ultrasound has taken you in one direction. Whatever the possibilities that you had the infection, whether it was hydronephrosis and secondary infected,
yes, sir.
or pyonephrosis or polycystic kidneys,
There was no
they
evidence
are
of hydrouretronephrosis.
so they are probably at this stage they are out, right?
Yes, sir. And sir, the possibility was kept of Wilms tumor and renal lymphoma. So again, the ultrasound was repeated, and it showed again bilateral enlarged kidney with the similar size, and it was diffuse heterogeneous hypoechoic and hyperechoic areas in both kidneys, and associated with increased vascularity. There was loss of corticomedullary differentiation in both the kidneys, and urinary bladder was distended, walls were echo-free, and IVC was normal. So impression of bilateral renal lymphoma was made.
So how the ultrasonographic picture would differ between, say, a lymphoma or a Bim's tumor, and what is the basis on which it is being labeled as lymphoma or likely?
Sir, both will present with areas of necrosis, hemorrhage, and calcification. But sir, the Wilms tumor will, in some cases, will also have extension to the vein and the IVC. So it can also show. And sir, calcifications will not be there in Wilms tumor.
Is there a difference between uniform versus uniform enlargement of the kidney versus a localized mass arising out of, say, one pole of the kidney?
Yes, sir. Wilms tumor will occupy one pole of the kidney, and it
Mostly,
will be more
yeah,
heterogeneous
yeah.
as compared to lymphoma.
So here they say there are focal areas of infiltration
Yes, sir.
within that enlarged mass.
Yes, sir. Whole of the mass was grossly enlarged, and there was diffuse heterogeneous hypoechoic and hyperechoic areas
Okay.
in both the kidneys. And
So
sir,
makes lymphoma a more likelihood according to the ultrasonographic
yes,
findings.
sir. Yes. And
Okay.
sir, on complete blood examination, sir, hemoglobin at the presentation was 8.6, and total leukocyte count was 6,300, and differential leukocyte count, lymphocytes were 38%, neutrophils 44%, and platelets were 1.98 lakhs. MCV was 79.3 femtoliters, and MCH was 24.4 picograms.
How much is the hemoglobin you said?
So 8.6.
8.6. So moderate anemia.
Yes, sir.
Okay.
And sir, platelets were 1.98 lakhs. They were normal, and TLC was also in normal range. And on peripheral smear examination, there was mild anisocytosis, normocytic, normochromic with few microcytic hyperchromic cells, and there were no blasts seen. No blasts were there. And on biochemical parameters, electrolytes, sodium was 132, potassium was 6.6, and kidney function test revealed urea 41, creatinine was 1.8, and calcium was 5.
So they are elevated, urea
Yes,
and creatinine
yes,
both
sir.
are elevated.
Urea and creatinine were elevated, and potassium was
More
also
of creatinine, urea is not all that increased.
yes, sir.
Okay.
And sir, calcium was 5, and phosphate was
Calcium, this is
This you're
total
talking-
calcium is 5 gram or is
No.
it ionized?
Sir, it was total,
Okay.
and sir, phosphate was 6.6, and uric acid was also done, which was 15
Okay. So you have a uric acid which is
raised, and
grossly increased,
and
right?
phosphate also on the higher side,
Right.
and potassium was 6.6, slightly on the higher side.
So
Higher side.
and the kidney function impairment,
Yes, sir.
right? So what does this mean? So yeah, tumor lysis syndrome, and so now within those say differential diagnosis of tumors, what becomes more likely? Yeah, lymphoma becomes more likely, and why you said Burkitt's? Yeah, so if you go by the statistics, the Burkitt's is the one which at presentation also might have tumor lysis syndrome. Others also might have, but it's more likely.
Yes, sir.
And compared to WIMS, obviously the lymphomas would be more likely to cause tumor lysis.
Yes, sir. Sir, it is.
So, just for the benefit of the other pages, can you define the tumor lysis syndrome?
Yes, sir.
What are the cutoffs that you use to call it? tumor
Sir,
lysis syndrome?
the most tumor lysis syndrome is a metabolic derangement. It is mostly seen in malignancies, and it can spontaneously occur in malignancies. Also, when we start chemotherapy, then also the chances of tumor lysis syndrome is there. So Cairo and Bishop classification is there to classify tumor lysis syndrome. It is biochemical tumor lysis syndrome and clinical tumor lysis syndrome. And biochemical includes 4 parameters: potassium, phosphate, uric acid, and calcium. So to label as tumor lysis syndrome, 2 parameters should be there. So hyperkalemia should be there. The value is more than 6 millimoles per liter, and in phosphate, hyperphosphatemia should be there, and the value is 6.5 milligrams per deciliter, or more than 25% increase from the baseline. And hypocalcemia, it should be less than 7. Total calcium should be less than 7 milligram per deciliter, or it should be decrease in value 25% from the baseline. And the uric acid, it should be more than 8 milligrams per deciliter, or increase in value 25% from baseline. So 2 out of 4.
So in all these 4 parameters, rather calcium, phosphorus, uric acid, and potassium, the change of 20%, 25% from the baseline, right?
Yes, sir.
That is one. And second is the 6, 6.5, 7 and 8.
8 values.
These are the cutoffs for the parameters. Okay.
And sir, to remember, we can know the underlying cause, that in tumor lysis syndrome, the tumor cells are getting lysed. So the contents of the cell which are necrosed are liberated free in the surroundings. So potassium will be raised and phosphate will be raised, and by combining with phosphate, calcium will be low, and nucleic acid will be degraded to uric acid. So uric acid will also be raised,
Elevated.
and it can lead to renal failure also, because it exceeds the capacity to excrete
Uric acid.
uric acid.
So why the renal function impairment occurs? Like in this child, maybe it's related to that.
Sir, it could be because of tumor lysis syndrome itself, or sir, the malignancy is in kidney, so we can also attribute it to the lymphoma malignancy itself.
Okay.
So we cannot exactly decide what leads to.
Okay. So
renal failure.
what next investigation to arrive at a diagnosis?
Sir, We did fine needle aspiration cytology, but it did not. It suggested the renal lymphoma likely to be Burkitt's, but for that we did renal biopsy, which was confirmative.
Okay, so renal biopsy was done and that showed. Can you read out the report of biopsy if you have?
Yes, sir. Sir, renal biopsy, B cell non-Hodgkin's lymphoma. So CD10 was positive, CD20, Ki67 was positive in more than 90% cells, and it was BCL2 negative. And immunohistochemistry was suggestive of Burkitt's lymphoma. And flows, sir, yeah.
Okay, so they have immunohistochemistry and the markers which are
Suggestive of
suggesting Burkitt's lymphoma.
Yes, sir.
Okay.
And so there was no other focus for malignancy.
Anything else was done for this one?
Uh,
More marker was put?
Sir,
Anything else can be done?
make
See, these markers like 10, 20 you said, they are for B cell. And diffuse large B cell lymphoma
T cell.
Burkitt's, they mimic very closely.
yes. Ma'am.
This Ki is also positive in diffuse large B cell,
Yes,
10 is
ma'am.
also positive.
Hmm.
But BCL2
Was negative.
was negative, which is more in favor of Burkitt. And CMYC
CMYC was done.
was done, which is more in with Burkitt's lymphoma than diffuse, because though treatment is same, but still we need to
Establish the
establish
diagnosis.
the diagnosis.
Yes, ma'am. And ma'am, the urine routine microscopy showed RBCs which were full field, and protein was 2+, and culture was sterile. But ultrasound did not show any hydronephrosis or pyonephrosis.
Okay. So what next needs to be done?
So as the diagnosis we have reached, like Burkitt's lymphoma, so first of all, before starting the treatment, we need to stage it and classify the category so that the treatment or chemotherapy can be decided. So for staging, we need to do few investigations. Radiological investigation will include contrast enhanced CT scan. So we did contrast enhanced CT scan, chest and pelvis, to look for any other mass or primary lesion which can lead to renal enlargement or metastasis, and the extent. And also we did bone marrow aspiration and biopsy, bilateral side, and CSF analysis for any blast or malignant cells. So for staging purpose.
Okay. So what was the reports of CT scan, chest and abdomen?
Yes, sir. CT
Is
abdomen.
there a disease outside these kidneys?
No,
in,
sir.
In abdomen, any lymph nodes, regional lymph nodes or anything?
No, sir. Sir, the disease was confined to kidneys only, and the findings were similar to ultrasound findings, but more precise. And sir, there was mild splaying and encasing of bilateral renal calyceal system, renal pelvis, and upper ureter and renal vessels with the mass. And there was mild displacement of inferior vena cava, and rest
That
was
is all
normal.
because of the size, in
Yes,
fact.
sir. And rest of the examination was normal.
Okay. And
Sir,
liver spleen?
Sir, not enlarged.
The nodal involvement.
No nodal involvement.
No nodal involvement. Chest is also
Chest
fine.
and pelvis
Okay.
both normal.
Right. So,
So other investigations also
Yeah.
we can do after staging to start chemotherapy. Like we have to, as we are starting with immunosuppressive therapy, so we will we will rule out tuberculosis. So we will do chest X-ray and Montus, and we can also rule out
yeah, once
infection.
we have CT
CT.
scan, we don't need the
It's a
chest
mon-
X-ray anyway. Mantus, of course, is required.
Yes, sir.
Ah.
Sir. And sir, HIV and HBs antigen and anti-HCV we can rule out.
Okay. Why HIV
So-
particularly?
Sir, immunosuppressive therapy. we are
Okay.
giving.
And is there association between
Yes, sir.
HIV infection and
Yes, sir.
lymphomas?
Yes, sir.
Yeah. So,
Anything else? What all are the other associations with lymphoma?
Yes.
EBV is infectious. Any
HTLV.
apart from infectious causes, any other associations? Yes. Hmm.
Right. So,
Protons.
Anything else you would like to add?
Bruton's agammaglobulinemia and Bloom syndrome.
so these diseases also should be, their physical markers should be looked for. These conditions like combined variable immunodeficiency or SCID, or they would be, I mean, manifested by this age, isn't it? What about VAS? That also should have manifested by this age, right? What are the manifestations in VAS? Right. So eczema, thrombocytopenia, and infections, right? And okay.
And sir, also we should keep in mind the history of radiation exposure and the previous drug intake, especially immunosuppressive drugs, and rituximab also is implicated in development of lymphoma.
Okay, that is
So she-
theoretical, but it's a good information that these are predisposing factors for
And sir,
lymphomas.
CSF cytology and bone marrow examination did not reveal any malignant cells.
So can you stage this one?
Yes, ma'am. The stage was stage 3 with risk group B category.
Why stage 3?
Sir,
How it is? How do you decide stage 1, 2, 3, and 4 in non-Hodgkin lymphoma?
sir, we stage the non-Hodgkin's lymphoma according to St. Jude's classification. It is divided into 1, 2, 3, 4 stages, and stage 1 is any extranodal or nodal on the same side of the diaphragm, and stage 2 is any two nodal or two extranodal or any extranodal with regional lymph node involvement on the same side of the diaphragm, or any abdominal with 90% resectable mass, excluding mediastinal masses. And stage 3 is sir, any nodal or extranodal disease on either side of, on opposite side of the diaphragm, and abdominal which was not resectable, and intrathoracic and paraspinal and
Yeah.
With
So all tumors which are
intraabdominal.
mediastinal or thoracic, they are stage 3. And abdominal, when the resection is not, complete resection is not possible, that is stage 3, right? But as the renal lymphoma itself is something very uncommon, and we had done the bone marrow biopsy in this child because to get the answers, I mean, after FNAC we did that so that we save some time before, I mean, the biopsy report was not yet available when we did the bone marrow biopsy.
Yes, sir.
Okay. So it is stage 3 because of the unresectable abdominal tumor being present. Okay. So I think we can see the some review on tumor lysis syndrome, and
Renal lymphoma.
then we can discuss what happened to this child, how we have managed. Okay. Dr. Puneet. Thank you, Pritam. You can sit down here or the group.
Good evening, everybody. We've already had a good discussion on tumor lysis syndrome, but a brief overview again. It is a potentially fatal metabolic complication due to rapid release of intracellular metabolites from necrotic tumor cells. So tumor cells, when they proliferate rapidly, there will be their breakdown, and when they break down, all their intracellular components would be released. What these intracellular components consist of? Potassium. Potassium is very high in the intracellular fluid. Phosphate is very high in the intracellular fluid. So these components would be released out of the necrotic tumor cells. When these come out, normally the kidneys will tend to excrete them. But in a highly overloaded state, when the tumor mass is excessive, this would exceed the excretory capacity of the kidneys, and therefore there will be accumulation of this intracellular metabolites in the blood, which will lead to this metabolic complication. The end point of all these metabolic complications is acute renal failure. So this is what is tumor lysis syndrome. Tumor lysis syndrome can occur either 3 days prior to the onset of chemotherapy or can continue up to 7 days after starting the chemotherapy. So 3 days prior to chemotherapy means something like spontaneous tumor lysis syndrome. Like some of the PGs have already mentioned, those tumors which have high burden like Burkitt's lymphoma, they have a doubling time of almost 24 hours. So in that case, spontaneous tumor lysis is common. The pathogenesis, so we have tumor cells. When we give cancer therapy, the tumor cells break down. So intracellular components like potassium is released. This leads to hyperkalemia. Then there is release of intracellular phosphate. This leads to hyperphosphatemia. The phosphate combines with the serum calcium. So calcium phosphate products are precipitated and it leads to hypocalcemia. And also there is release of nucleic acids. Nucleic acids are broken down into uric acid, so there is hyperuricemia. There is precipitation of these calcium phosphate crystals and mainly uric acid crystals into the renal tubular cells and also the glomeruli, and this leads to acute kidney injury. What are the risk factors for TLS? Patients at high risk include Burkitt's lymphoma, lymphoblastic lymphoma. Both Burkitt's lymphoma and lymphoblastic lymphoma are two forms of non-Hodgkin's lymphoma only. Lymphoblastic lymphoma is most of the time T cell. 80% of lymphoblastic lymphomas are T cell, but it is the B cell lymphoblastic lymphoma which predisposes the child to high risk of TLS. The third is ALL with hyperleukocytosis, that is TLC of more than 1 lakh. And the fourth is AML with TLC of more than 50,000. These are the 4 high risk factors for tumor lysis syndrome. This is mentioned in Lanzowski. So, as we've already discussed, there is this Cairo-Bishop classification for TLS. The criteria are divided into biochemical and clinical. So, biochemical, you can learn like this: 6, 6.5, 7 and 8. Hyperkalemia of more than 6, hyperphosphatemia of more than 6.5 milligram per deciliter, hypocalcemia of less than 7 milligram per deciliter, and hyperuricemia of more than 8 milligram per deciliter. When any 2 or more than 2 of these values are abnormal, it classifies as biochemical TLS. Apart from these absolute values, there can be more than 25% increase or decrease from the baseline, which will help in classifying it as biochemical TLS. For clinical TLS, we have 3 system involvements: the kidney, the brain, and the heart. So in kidney, the serum creatinine rises to more than 1.5 times the upper limit of normal, or there is presence of seizures, or there are cardiac arrhythmias or sudden death. Any one of these clinical features along with biochemical evidence of TLS classifies as clinical TLS.
So this child would be classifiable as what? Clinical or biochemical? Why? What was creatinine?
This child had, see,
Creatinine of 1.8. So for this child, that is
liters per meter square per day, the normal fluid requirement. But in this TLS, to prevent TLS, we give double this, that is 3 liters per meter square per day. And this has to be potassium free because we know that tumor cells are going to release a lot of potassium, and this can predispose to hyperkalemia. We have to monitor the urine output. In fact, input-output monitoring has to be very stringent because these children need to maintain a urine output of more than 100 ml per meter square per hour. Urine output less than this would predispose them again to renal failure, as there will be crystallization of uric acid. If despite these TLS fluids, the child is having poor urine output, you can add furosemide at the rate of 0.5 to 1 mg per kg per day. These doses can be repeated over the day. If on stat doses of furosemide also the child does not improve, you can give mannitol 25%, 0.5 mg per kg per dose, which can be repeated 4 times in the day. If despite 25% mannitol, the child does not improve, you can start on furosemide infusion at the rate of 0.05 mg per kg per hour.
So, Pritam, what was done to this child as far as this case is concerned?
So keeping in mind the possibility of tumor lysis syndrome, we started the hydration at 3 liters per meter square per day, which was the fluid was potassium free, and we were monitoring urine output also, which was less. So we shifted the child in intensive care unit for peritoneal dialysis. Although it is not indicated, but we did not have facility for hemodialysis. So we
What was the indication for
Doing PD.
so acute kidney injury was there,
This-
and it was not responsive to medical management.
So what we are discussing over here is prevention of tumor lysis syndrome. That is, prior to the child developing an acute kidney injury, these are the measures that we can take. So in this child, despite having given fluid of 3 liters per meter square per day, urine output was poor, and with the rising urea and creatinines, we had an idea that the child had already acute kidney injury occurring. So therefore, we could not have overloaded him because his urine output was decreasing. Therefore, we had to resort to a peritoneal dialysis. However, you should know that actually in TLS, hemodialysis is the modality preferred over peritoneal dialysis. Why? Because uric acid is not excreted well, it cannot be removed well via a peritoneal dialysis. It is via hemodialysis that uric acid can be removed, which needs to be done in such cases. Okay, and once hyperuricemia occurs, as a preventive measures, we should start allopurinol. To make you understand it better, you should know that the tumor cells release nucleic acids. Nucleic acids break down to give purine. Purine is broken down into hypoxanthine, then xanthine, and xanthine is converted by xanthine oxidase to uric acid, which has a low solubility at acidic pH of the urine. Right, and this uric acid can be converted by one of the drugs known as the recombinant uric oxidase, rasburicase, into allantoin, which is highly soluble. It is almost 10 times more soluble than the uric acid and is easily excreted in the urine. So what we commonly give is allopurinol at doses of 300 mg per meter square per day in 3 divided doses. So this allopurinol blocks the conversion of hypoxanthine into xanthine and xanthine into uric acid. So in net effect, the total amount of uric acid decreases. Therefore, uric acid crystallization in the kidneys will decrease. But you should also see from this that once hyperuricemia to a large extent has set in already, allopurinol will not be that effective because it does nothing to the already formed uric acid. Right, so if the child already has TLS, rasburicase is the drug of choice, but because of limitations, because of availability issues, because of monetary issues, we were not able to give rasburicase to this child. Rasburicase is to be given at the doses of 0.15 to 0.2 mg per kg per day IV. So once again, in TLS, rasburicase is the treatment of choice. Also, I would like to add another thing on alkalinization of urine. Can anybody of you tell me why alkalinization of urine was previously done? Exactly. So the previous theory was we need to alkalinize the urine because it is going to prevent precipitation of uric acid crystals, because uric acid precipitates as an acidic pH. If we alkalinize the urine pH will become alkaline and uric acids will not precipitate. But what is the problem with it? Now it is no longer recommended alkalinization of urine. Why? Because in that case, when allopurinol is acting, we are producing, the body is having more of xanthine and hypoxanthine. Now at an alkaline pH, hypoxanthine and xanthine tend to crystallize more. So anyways, if you don't have uric acid crystals, the body will produce more of xanthine and hypoxanthine crystals. So crystallization would occur. Plus, calcium as phosphate precipitation also is hastened at an alkaline pH. So that is why the reason that alkalinization has now removed from a recommendation. Other issues like hyperkalemia management, we are well versed in. So acutely, you can give calcium gluconate, 10% dextrose, 1 ml per kg. Insulin dextrose and potassium K-bind can be given to the child, 1 gram per kg per dose. Hypocalcemia is to be treated only if it is symptomatic. Asymptomatic hypocalcemia is not to be treated. This particular child had hypocalcemia and he had developed hypocalcemic seizures. That is why IV calcium gluconate had to be given to this child. Apart from that, we have hyperphosphatemia. For hyperphosphatemia, we can give aluminium hydroxide at the rate of 150 mg per kg per day. This again, hyperphosphatemia is to be treated only when it is leading to a hypocalcemia that becomes symptomatic, right? Because hyperphosphatemia is indirectly going to lead to hypocalcemia, and if hypocalcemia becomes symptomatic, then you have to treat for hypophosphatemia also. So aluminium hydroxide 150 mg per kg per day every 4th hourly to 6th hourly is to be given orally. A common preparation which has aluminium hydroxide, you have aluminium hydroxide tablets available 500 to 600 mg. Digene that we commonly use has aluminium hydroxide. Apart from that, we can use calcium carbonate at the dose of 45 to 65 mg per kg per day, again to be given 4th to 6th hourly. And we have sevelamer, which is a non-calcium phosphate binder, which is given in the doses of 400 mg BD. If in the unfortunate event of a child developing renal failure, we have to resort to hemodialysis. A less good option is peritoneal dialysis if we don't have hemodialysis available. This
one more important thing regarding while you are managing TLS is that the biochemical parameters need to be monitored at least 6 to 8 hourly. It's not that you do in the morning and then your treatment is going on, because these changes are occurring very rapidly because of interventions that you do and because of this cell. It's not like there might be situations when, despite some tumor lysis syndrome setting in, you need to reduce the tumor burden because it's going to harm otherwise. Like say there is hyperleukocytosis and you can't allow it to persist. There might be already setting in of biochemical TLS. So in that situation, your monitoring has to be really vigorous. 3 to 4 times in a day you might require.
right, sir. Now a very brief review about primary renal lymphoma. As this child was finally diagnosed to have renal lymphoma, which was limited to both the kidneys, it is something very rare. The commonest, to give you an overview, commonest malignancy in children less than 15 years is leukemia. In children between 15 to 19 years, lymphoma is the commonest malignancy, and of all these lymphomas, NHL accounts for 60% of the lymphomas in children and adolescents. The organs involved in lymphoma, they say that 35% of it is abdominal. Abdominal means the ileocecal region, the ascending colon and the appendix. 26% of the cases have mediastinal involvement. Mediastinal involvement means mediastinal lymph nodes, the pleura and the thymus. 14% had nodal involvement. So you have different lymph node groups in the body. You have the clavicular group, the infraclavicular, supraclavicular, axillary, femoral, popliteal, inguinal, mesenteric lymph nodes. So 14% of them had nodal involvement. 13% had head and neck involvement. Head and neck involvement means the jaw, the parotid gland, and the 11% were constituted by other side malignancy, NHL. So these are the the organ involvement that we have seen, and in the others we have bone marrow lymphoma, non-Hodgkin's lymphoma, CNS, skin, orbit, thyroid, bone, gonads, and finally the kidney. Kidney involvement is, isolated kidney involvement is pretty rare in non-Hodgkin's lymphoma. There are autopsy series that have been done which say that in disseminated non-Hodgkin's lymphoma, that is when you have stage 4 non-Hodgkin's lymphoma, almost 50% will have kidney involvement in the autopsy series. But when you talk of primary renal lymphoma, where only the kidney is involved and there is no other evidence of involvement elsewhere in the body, as in this case, such cases are less than 0.7% of all non-nodal non-Hodgkin's lymphoma. So primary renal lymphoma is less than 1% of the renal tumors, and it constitutes less than 7.7% of all extranodal lymphoma. Till 2010, only 100 cases were reported worldwide, and most of them were adult cases. Pediatric cases are limited to around 20 till date. How they have defined different people, since it's an upcoming entity that has been recognized, that uniform definition is not available, but by and large they say that involvement of the kidney, starting in the kidney or just limited to it, will classify as primary renal lymphoma. So a renal localization of lymphoma in the absence of clinical manifestations of lymphatic involvement of other organs would be primary renal lymphoma. Also, suppose the kidneys are enlarged, they are lymphomatous, and there are very small lymph nodes associated alongside which also show lymphoma deposits, it will be considered as primary renal lymphoma, because you expect that it is from the kidney that the nodes have been involved, and not the nodes having been primary and kidney have been involved secondarily. These are the criteria. Stringent criteria were applied by Malbrain et al. In 1994, and he said that there are 6 things which need to be present to call it primary renal lymphoma. Renal failure as the initial presentation, which was the case in this child. At the time of presentation itself, he had deranged urea and creatinins. Enlargement of the kidneys without obstruction. So the important thing is that the kidneys are enlarged, but there is no obstructive cause to it. As we had explained in our ultrasound, there was no hydrouretronephrosis. Then there has to be absence of other organ or nodal involvement. We did CECT of the mediastinum pelvis apart from the abdomen, and we found that no other lymph node groups were involved in this case. There has to be an absence of other causes of renal failure. Diagnosis has to be made by renal biopsy, which was made in this case, and there has to be a rapid improvement of renal function after the therapy. So for your information, I would like to tell that once this child had developed TLS, we had started him on TLS management, and we had also started peritoneal dialysis, but initially there was minimal improvement in this child. Then we thought that probably this is primary renal lymphoma, and his acute renal failure is because of the renal lymphoma per se. So we had started chemotherapy, albeit in a phased manner, because we were scared of worsening the TLS. Once we started chemotherapy, actually the child started showing improvement in his clinical and biochemical parameters. Pathogenesis is still a dilemma, because the problem is that non-Hodgkin's lymphoma has to arise from the lymphoma cells, and a kidney does not have any it is not a lymphomatous organ. So where do these cells penetrate from? They say that this B cell infiltration can occur in response to intense chronic inflammation. For example, if a child has a known case of SLE, Sjogren syndrome, or he has EBV infection or chronic pyelonephritis. In that case, because of the constant inflammation that is ongoing, there will be infiltration of the B cells, and these B cells will later transform into malignant B cells, leading to lymphoma. Second possibility, they said, is that there are some B cells present in the hilum of the kidney. So these will go into develop the renal lymphoma, or perirenal adipose tissue can be the source of these B cells. Clinical features, mostly in adults, unilateral renal masses have been found, but in children, bilateral renal masses have been found to be commoner than unilateral renal masses. Acute renal failure is the most common complication which has been found of primary renal lymphoma. The rarer manifestations have been nephrotic syndrome, renal tubular acidosis, hematuria, hypertension, fever, and constitutional symptoms. This child had Burkitt's lymphoma. When you talk of histology of this primary renal lymphoma, diffuse large B cell lymphoma was the commonest one which was found. Ma'am was also discussing about the immunohistochemistry. She said that BCL2 positivity favors DLBCL, whereas BCL2 negativity favors Burkitt's lymphoma, and c-Myc positivity favors Burkitt's lymphoma. In this child, we had Burkitt's lymphoma positive, though overall world over, the cases of primary renal lymphoma which have been reported have DLBCL as the more common finding. Radiological presentation, again, sir was discussing the difference between Wilms tumor and renal lymphoma. In renal lymphoma, when a series of patients was checked, it was found that most of them, almost 60% of them, present as multiple passes in the kidney. Solitary mass can also be present in 10 to 20% cases. Diffuse infiltration is present in 20% cases, and perirenal involvement in 10% cases. So most of the time, multiple renal masses are present as a lymphoma involvement. At least as far as the reviews say, this is the commonest presentation. Yeah.
She is
Like-
mentioning for renal lymphoma.
I am giving the statistics plainly for
primary renal lymphoma.
So what you're talking about is the complete non-Hodgkin's lymphoma. It is not restricted to the kidney. In fact, kidney is only 0.7% of all the non-nodal non-Hodgkin's lymphoma. So we are just talking about
Out of
primary renal lymphoma in this case.
Even that statistics of Burkitt's being most common, we have to know here in India what is the Burkitt's has very differing prevalence in different countries, and its prevalence is related to some infection, EBV infection and malaria and all that. And there are some Burkitt's cases which occur in epidemics, small epidemics they occur in Africa. So I don't know in India if it is really in large is large data there on, but is whether it is Burkitt's which is more common or the other subtypes which are more common.
Treatment, as Dr. Preetham has already discussed, over here we follow the LMB 96 protocol, and the treatment that we administer is based on risk stratification. The treatment we have given from primary renal lymphoma is akin to what we use for non-Hodgkin's lymphoma. And risk stratification, she's already discussed, is based on the staging, the surgical resectability, bone marrow and CNS involvement. Drugs used are cyclophosphamide, vincristine. Cyclophosphamide is one drug to which Burkitt's lymphoma is very sensitive, non-Hodgkin's lymphoma and Burkitt's. Apart from that, these are the drugs that we have used in this child. Prognosis, earlier case reports till 2006 suggested a very poor prognosis, and they said that survival was as less as 9 months to less than 1 year after the diagnosis, but recent case reports have suggested better survival rates. In fact, our own child was treated on LMB 96 protocol, and he's still in our follow-up, and his renal masses have regressed completely, and he is now in our follow-up.
Almost 5 months.
Almost 5 months post-treatment and post-regression of his tumor, he's with us. Thank you.
So I think this was interesting to know that though bilateral renal masses are quite commonly encountered in pediatric practice, but the causes could be quite varied. I mean, it could be inflammation, infection, or an obstruction, urinary obstruction leading to hydronephrosis, and maybe congenital disorders like polycystic diseases or tumors, the renal tumors or the unusual tumors that we had here. And though rare, but it was manageable. It sort of regressed with treatment. Only time will tell whether he has any. In Burkitt's, the relapses, if at all they have to occur, they occur within few months. So if he crosses another couple of months, maybe we might declare him as cured of the disease. And one thing important is that probably the delay in sending the child to us led him to require all that he required in the management, the dialysis and all that. The TLS had already set in when he came to us. So again highlights that importance of knowing what is occurring and where the child should go for the treatment. And cancer is curable, so that should be the message from this case. Thank you very much.